Dr. Theodore Schwartz has been practicing neurosurgery for more than 30 years. He is known for innovating new surgical techniques, for contributing to an immense amount of new research in the field, and for educating and mentoring the next generation of neurosurgeons. His recent book is Gray Matters, a biography of brain surgery. It's a very readable history of neurosurgery. Dr. Schwartz, welcome.
Hey, William, thanks so much for having me. I'm excited to be here.
Um, Many of our viewers have to perform tasks well under high pressure, but probably not under the pressure you're regularly under in a brain operation. How do you prepare yourself physically, mentally, and emotionally for what you do?
Yeah, the reason I wrote the book was to give people a window into what brain surgery is really all about. There's a lot of myths out there as to what people think brain surgeons do. And then there's reality of what we really do day to day. And the truth is, as much as there's a myth of brain surgery being this incredibly difficult task requiring immense focus, um, the truth is it's even more challenging than people think,
Mm.
because it's not just the task of doing surgery, but it's the emotional weight of what we're doing and the people we're taking care of, and what's on the line every time we do one of our operations. So, the training is, if we go to college, right? There's 4 years of college, there's 4 years of medical school. A lot of neurosurgeons will take a year off and do research, which adds another year. And then the residency itself is 6 or 7 years after that. So most neurosurgeons don't finish their training till they're 33, 32, early 30s, which is a long time to be learning how to do something. And it's really an apprenticeship where you're in the operating room, operating with someone more senior, watching everything they do. They're letting you do a little bit more each time. So there's graded responsibility, obviously, because really the only way to learn how to do it is by doing it on human beings.
Mm.
And given that everything is on the line at that moment, we really can't let the trainees just jump in there. So um, you have to learn how to link your brain to your hands, and do this repetitive task that you do over and over and over again, day in and day out. Residents will literally do thousands of operations, tie tens of thousands of knots, and just keep learning how to move their hands and working in these very, very tiny, tiny corridors. A lot of the work that we do is under a microscope. So um, I like to liken it to making 1,000 decisions like a soccer game on a field the size of a postage stamp.
Mm.
You really are um, working in a very, very tiny area because the microscope is so intensely focused that you really can't see more than a centimeter or two in either direction. And it's a very dark, narrow corridor there that we're working down. And in order to build the stamina, the reason I give you this whole long um, rendition of what it takes to become a neurosurgeon is that it requires an enormous amount of stamina, because you are focusing for hours on end, keeping your body sometimes in very unusual positions with your head bent in one way or another, with your arms in front of you, being braced in very particular ways to learn how to reduce your tremor. You have to control your breathing while you're operating, because every breath that you take will affect the physiology of your hands and the movements of your hands. You have to be aware of your heartbeat. You have to know how to calm yourself. And so there is an enormous amount of physical training and control required to perform neurosurgery at its highest level. And that requires the things you'd imagine: sleep, exercise. There's a lot of neurosurgeons that have had a lot of spine surgery over the years done on them, because
Mm.
they've they've held themselves in such unusual positions for such long periods of times that their spines just give out after a period of time. So in order to have a career with longevity, you really have to take care of yourself, not only physically, but mentally. And you have to
Mhm.
train yourself to be calm under pressure, because some of the situations we face where someone's life is on the line and there's bleeding that obscures your field of view, where you can't see anything but blood. Imagine we're focusing in on very small areas, and if a little bit of bleeding in there, it's like everything, all you see is red. So you really have to learn how to control that and calm yourself and get in this Zen-like meditative state in order to maneuver, make the right moves to get control of what's going on, to move
Mhm.
the surgery forward. So, bit of a long operation discussion of what an answer to your question, but maybe raise some additional questions.
Well, yes. I'm wondering how you keep yourself calm, how you perform at a high level. Do you lean into the enormous consequences of what you're doing, or do you just kind of concentrate on the mechanical task that needs to be done?
Yeah, the important thing is to not lean into what you're doing, and there's many ways that that is done. So, the first thing that I love about neurosurgery is that um, when you drape a patient out, when you drape out the operative field, all you see is a little square about this big of skin, right? The human being involved and attached to that area is gone. They're under drapes. You don't see them.
Mhm.
And that's a huge advantage because you're just working on a technical task and you will then expose the brain and the tumor and where you're working. It's very important, in my opinion, to be able to go back and forth between realizing the gravity of what you're doing and also suppressing the gravity of what you're doing. You can't go all one way or the other. You have to be able to go back and forth. So, for example, um, when you're performing a technical task and someone's life's on the line, you can't think at that moment, "Oh my God, someone's life's on the line, and if I don't do this task correctly, they're not going to survive, or they'll never speak again, or I will disappoint their family. How will I live with myself?" So, to get that job done. On the other hand, there are moments where you have to make decisions in the operating room. Do I take this whole tumor out? How aggressive should I be? Do I put this patient at risk in order to get that last piece of tumor out?
Mm.
Where you have to ask yourself humanistic questions.
Right.
What would I want done if this were me on the table? What would they want done based on the conversations I've had with them preoperatively?
Mm.
So in those scenarios, you really do have to think about who you're operating on and what you're doing. And you can't just focus on the task, the mechanical task at hand, because you have to make the decision as to what to do based on a knowledge of what exactly you are doing and the ramifications of what you're doing. But then when you make the decision as to what to do, then you got to flip back to the mechanistic surgeon in order to get that job done as efficiently and as effectively as possible. And that's
Right.
really one of the difficulties of being a neurosurgeon or brain surgeon is you got to flip back and forth. You got to turn that humanity meter on and off constantly during an operation based on what sort of decision you're making. Is it a technical decision or is it a humanistic decision? Is it what to do or is it how to do it?
Okay. As you might know, I was named William after Dr. William Scoville, who you write about in your book.
Yeah.
Before I was born, he cured my father of quadriplegia, allowing me to be conceived. So, as you might imagine, I've always had a curiosity about my namesake. He had a very distinguished career, but he is mainly known, I think it's fair to say, for a misstep. Could you
Uh-huh.
talk a little bit about HM and the operation that left him an amnesiac?
Yeah. Bill Scoville is a fascinating character in the history of neurosurgery. And I think your experience with him is probably the more common, which is that he helped an enormous number of people. And he was thought of as a very excellent surgeon and a compassionate surgeon, although he was a little bit of a crazy man, a little bit of, I would say, impulse control, perhaps problems. But on the other hand, a very good technical surgeon. Um, he ran into trouble partially because of the time at which he lived, taking care of a patient named HM. Those were his initials. It wasn't his actual name. Um, Henry Mollison was his actual name, who had a seizure disorder. And at the time, uh, based on the work of another neurosurgeon named Wilder Penfield, who was working at the Montreal Neurologic Institute in Canada, it was known that a type of seizure called complex partial seizures often come from a part of the brain called the hippocampus. And that if you go in and remove that part of the brain, you can often cure people of their epilepsy. And Wilder Penfield had been reporting enormous success removing the hippocampus and curing patients of epilepsy. And when HM came to see Scoville, he knew about that. And he thought that was likely the right operation, was some removal of the hippocampus. But what was unique in Scoville's situation was that Scoville was also a practitioner of lobotomies. He did quite a few lobotomies. And we look back at the lobotomy with sort of disdain and contempt for the idea of doing this barbaric operation where, we go in and sort of scramble someone's frontal lobes to try to help them with mental illness. Although the truth was at the time, it was actually the best treatment for patients who were institutionalized with severe, severe depression and schizophrenia. We had no other treatment for them. We didn't have medications for them, and their lives were essentially over, and they were just kept in these institutions. And so Scoville used to do lobotomies at the request of psychiatrists who wanted them done. And he had developed a new way of doing it, where he would go in on both sides, sort of underneath the frontal lobes and come up from below, and then realized that he could actually see the temporal lobes and the hippocampus with his approach coming in on both sides. And so he made the illogical conclusion. He came to the conclusion, which is that if removing one hippocampus is good at stopping seizures, as Penfield showed, then maybe removing both hippocampuses, both sides of the brain, will be even better. And the problem was that nobody really knew what the hippocampus did at that moment in time in history. He didn't know, Penfield didn't really know. And it turns out that the hippocampus was incredibly important at consolidating new memories. And the reason why Penfield could get away with removing one hippocampus and curing epilepsy and not affecting memory is that those hippocampuses were diseased. They were diseased because they had epilepsy in that hippocampus. And if you remove that one, the other side that's intact will take up the slack. And Scoville didn't really understand this, and Penfield didn't really understand it at the time. So he tried this experimental surgery and removed both on HM and basically eliminated his ability to consolidate new memories. So he had no short-term memory. So you'd come in and meet HM, he'd meet you, he'd talk to you, and if you walked out of the room and walked back in, he'd have no recollection of ever meeting you. So really devastated his life, because if you have no memory, you lose your sense of self, you lose your sense of time. The memory is an incredibly important aspect of human consciousness and being. So he was almost like a goldfish. You think of a goldfish with no short-term memory, that was essentially him. And so Scoville is remembered for that mistake. Now, he didn't do it out of neglect or negligence or ill will. He was really trying his best to help HM. And from my understanding of speaking to people who knew Scoville, he was devastated by that outcome. And it haunted him, as it does all of us. And it speaks to the fact that so much is on the line when we do our neurosurgical operations. We make our decisions, 99.9% of the time out of compassion and a desire to help people. And because medical knowledge is not perfect, we don't fully understand everything about how the brain works. And because we're human beings and we're imperfect in everything that human beings do, mistakes will happen from time to time. And those mistakes haunt us and they keep us up at night. And we think about them constantly because patients are so angry and can be so resentful that the outcome hasn't been perfect. And we feel the same way, about it ourselves. And it's unfortunate that that's how HM is remembered, because from your family's perspective, he was a hero. And you wouldn't be here if it weren't for Scoville. You would not be here. And I tell a story about Scoville in the book after I talk about HM, because I spoke to someone who trained with Scoville, and this is a firsthand accounting of a patient he operated on named Gunther, who had a horrible complication. He was doing a spine surgery on him. He was doing it seated up. And one of the possible risks when you do a surgery on someone who's in the seated position as opposed to lying down is that air can get into a vein. And if the air goes into the blood vessels in the veins, it can travel to the heart and up to the brain. You can have a stroke. And this patient, Gunther, had the worst possible kind of stroke from an air embolus during his surgery, where you get locked in, meaning that he was paralyzed in his arms and his legs. He could not move, but he was awake and he was conscious, but he literally was bedbound, unable to move his body. So he had to be fed, he required care. His wife divorced him. His life was ruined by William Scoville, and Scoville was trying to help him. But in the story, what I try to express and what I learned is that on many weekends, Bill Scoville would actually go to the rehab facility where Gunther was living and sit at his bedside and spend time with him. and try to be a compassionate doctor, as opposed to just getting about him and ignoring him and moving on to other patients. He actually went back and visited him and brought him gifts and read to him, because he was so haunted by this horrible complication. Um, and that's one of the things that's really what makes neurosurgery so difficult right there, is that
Right.
yes, it is technically difficult.
Yeah.
And yes, it requires an enormous amount of training and sacrifice and focus just to physically do what you have to do to train your body to work at that microscopic level. But the hardest thing is the emotional aspect of it, because in every neurosurgeon's career, they're going to make a mistake and there's going to be a bad outcome, and they're going to have to live with that. And that's the emotional toil and toll that you have to pay as a neurosurgeon for choosing that career. And it's true in other fields of medicine, of course. I'm not trying to make it unique to neurosurgery, but it's what I know. It's what I do.
Right. Well, thinking about that HM operation, in your book, you also write about William Van Wagenen, who first severed the connection between the two sides of the brain for the same reason as Scoville, to treat seizures. And astonishingly, as you say, it doesn't seem to affect our functioning much when you split the brain in two. Now, they both had some reason to think their operations might help, for some reason to think they probably wouldn't do any harm. Is it possible that one got lucky and one didn't? And I guess what I'm trying to get at is, how do you know how much to experiment? How do you know how far you can push forward the state of the art and not put your patient at risk?
The answer, of course, is that you don't. And that, as with all science, you make your best guess with the best available evidence at the time. So the Van Wagenen story is, he saw that patients who had severe epilepsy, and again, these are patients who would be collapsing on the ground and, bang their heads and have severe head trauma, or burn themselves because they were carrying hot water or cooking, and they just had scars all over their bodies. Like, they obviously needed a treatment. And some of these patients would have a tumor growing in the corpus callosum, and that tumor would obliterate the corpus callosum, which is what connects the two hemispheres of the brain. We have a right brain, a left brain. They're two independent brains that are working inside, and there's a big communication that connects the two. And when the tumors grew in that area and obliterated the connection, Van Wagenen noticed that these patients' seizures got better. So here was a pathologic entity, a destructive tumor, and it was obviously, it was going to kill them eventually because of the tumor. But for a period of time, their seizures got better. And he thought, wow. And he could also examine their personalities and say, although the tumor is growing in the corpus callosum, they still seem to be functioning well. So maybe if I purposefully sever the corpus callosum, if I do in a more refined way what the tumor is doing, I can help these patients with their epilepsy. And indeed, that's what happened. And patients got better. And in fact, we still do that surgery to this day for certain patients who have what we call drop attacks, where they fall down and hurt themselves, because when you cut the corpus callosum, it prevents the seizures from spreading from one hemisphere to another. So he got lucky, at the time he had some evidence that it was safe to do that, right? I would say that Scoville did not have adequate evidence that it was safe to remove both hippocampuses. And so that leap is why he made his mistake. And now, obviously, if you want to do something experimental or new, you have to pass it by an institutional review board, an IRB. You can't just go and do it, and so those IRBs will review the best available evidence at the time and weigh the risks with the benefits, and decide whether they're going to let you do that experimental procedure or try that new drug. And sometimes the risks will outweigh the benefits, and they will make a mistake, right? Even today, that can happen because we don't understand everything about the way the body works, and we're trying new things. But we make our decisions based on the best available evidence at that moment in time to try to make it as safe as possible. But it's going to be imperfect.
Okay. One thing I'm also curious about, you talked a little bit about lobotomies, and I guess the thing that bothered me about the lobotomies was that it was the lobotomists that decided how successful they were. and that there might be some risk of perhaps becoming a little too in love with your handiwork and some cognitive bias from that. And I assume that's probably true in other neurosurgeries. So you talked a little bit about IRBs. Tell me a little bit about how you can protect yourself against that kind of
Well,
error.
I, I, I am not sure I totally agree with what you're saying because at the period of time of the lobotomy, which is in the 1950s, um, there were no rules and regulations in place, or at least they weren't that rigidly enforced, or they weren't that well worked out about, how to do human experimentation, how to try new things on humans. It didn't exist. There were some lobotomists who were very aggressive with their lobotomies, and as you said, were determining the success of their procedures. And that was problematic for sure. But there were other neurosurgeons who performed lobotomies, and they studied them. And they would have a psychiatrist, an objective psychiatrist, examine all the patients beforehand. They would do a lobotomy on a certain group of patients, not do a lobotomy on another group of patients. And then they would have the psychiatrists examine those patients afterwards and try to compare the two groups to see, did the lobotomy make these patients better compared to the ones who didn't have the lobotomy? And that's the scientific method, right? You have two groups, you try to be objective in your analysis, you perform whatever you're going to do on one, you have a control group that you don't perform it on, and you objectively assess their outcome. That was done in the 1950s for the lobotomy. Those studies were done. And in fact, they showed that there was a significant percentage of patients who actually did get better. It was an effective treatment. It's just that there were a lot that didn't get better, and there were a lot that got hurt as well. And so it didn't justify doing the procedure. But there's no question that it actually worked in a subset of patients, but we had no idea, they had no idea how to identify who that subset of patients was that was going to improve, and technically what they had to do to get the best outcome, which is why it was ultimately abandoned. That was a long time ago, right? So now, fast forward 80 years, or 70 years, medical treatments that are released into the world have been very carefully vetted through certain studies and approvals by the FDA and, IRB controlled studies to try to make sure that what's released into the world is as safe as possible. Are mistakes going to be made? Are treatments going to be released that are potentially unsafe sometimes, or where there may be benefit, but there's also risk? And, you have to really understand that. Absolutely. Absolutely. Doctors are not perfect. Scientists are not perfect. We're making decisions based on the best available evidence at the time, and we're human beings, and we're not perfect, but we're trying our best. So the problem is that that society latches onto the mistakes or latches onto the imperfections and then says, well, we can't trust the whole medical establishment because they made this one mistake. And I think that's a faulty conclusion. Really, the conclusion that should be drawn is, we need a healthy skepticism, and any scientist will have a healthy skepticism. But there is a process in place that is there to protect society and to try to only get safe treatments through. But every treatment that we do has a risk to it. But there's a risk to not treating, right? There's a risk to not vaccinating, as you know. And so, or not the disease running its natural course should be more risky than the treatment. And usually it is, but it doesn't mean that the treatment is perfect.
Okay. Well, let me tell you a bit about my father's case. When my family was living in Peru before I was born, he developed some symptoms and was diagnosed with what they thought was a herniated disc. A Peruvian surgeon operated, and my father was left quadriplegic after that operation. He didn't quite understand why or how. Then my father went up to see Scoville, and he thought it was a herniated disc at first too. But then on the operating table, he had the wherewithal to fish around, and he found a congenital cyst about the size of a grape. Scoville took it out, and the next day my father is walking, and within a year I'm conceived. I hear congenital cysts are rare. Have you ever encountered one?
Yes. We see congenital cysts fairly commonly because they can be picked up now on MRI scans very easily. And as you know, MRI scans are a fairly routine test. and often we'll pick up congenital cysts, some of which are symptomatic, some of which are not symptomatic, and they can be anywhere in the nervous system or in the body. It just means it's a cyst you were born with. Normally, if it's causing symptoms, then that cyst is enlarging in some way. There's something contributing to the growth of that cyst. So the term congenital cyst is sort of a vague term, because we now have more specific categories. There are things like arachnoid cysts, and we know what's causing them. And then there are different types of cysts that have specific names based on their etiology, some of which grow, some of which don't grow, some of which need to be treated, some of which we just follow. So congenital just means you're born with it, and cyst means it's a bag of fluid or protein. But we now know so much more than they did back then. So it would be interesting to go back, rewind the clock, get your father an MRI scan, or get better pathologists to look at what was taken out and really get a more accurate diagnosis for what he had.
Yeah. Actually, what happened, my father had 19 years of health, and then he started suffering some neurological symptoms again. He went up to see Scoville, and at that stage, like you say, before the MRI, they just had the myelogram at that time. He wasn't able to identify that the cyst had come back and what place it had come back in. So, I want to be clear. I don't blame Scoville at all, but my father is quadriplegic, came back, and he spent the last 19 years of his life in a wheelchair. I'm wondering, is there what is that dynamic whereby the operation seems to create some room for the cyst to grow or bloom? Does that sound
No,
familiar to you?
yeah, no, I don't think, I think you may be thinking of it in a way that is different than how I think of it.
Hmm.
I don't think the operation creates room for the cyst to grow. I think that Scoville probably punctured the cyst and
Uh,
it released its fluid, but he didn't remove the whole thing.
mhm.
And what happens when you puncture a cyst is that the cavity that was causing the problem collapses and the patient gets better. And the hole that you made in it, once the cavity collapses, scars over. And usually the wall of the cyst is producing fluid. That's why it becomes a cyst. So
Right.
once the hole you make collapses and scars over, the cyst will recur.
Okay.
And when the cyst recurs, it causes the symptoms again.
Right.
Because
So,
what you've done, and it may not have been safe to remove the whole cyst. The cyst can
right.
sometimes be so stuck to the spinal cord that you really can't take it out. All you can do is decompress it. A better treatment might have been to put a catheter in it and try to leave the catheter in to drain so that the cyst doesn't recur. But those catheters can clog and the cyst can recur anyway, even if you do that. So had he had another MRI scan, it might have shown that the cyst had recurred and he might have been able to undergo another surgery to decompress it and make him better. In my mind, that's the most likely
Mm,
scenario. I
mm.
don't think it's a situation where a surgery allows, a cyst to grow.
Okay.
Yeah.
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 That makes sense. That makes sense. And Scoville talked about removing adhesions in that operation. I assume that is kind of the stuff that grows around the sac, as you call it.
Yeah, there could be a lot of scar tissue
Yeah.
that
Yeah.
forms when you do a reoperation. That's the hardest part about doing a second operation is there's an enormous amount of scar tissue. So
Mm,
your best chance of curing someone and getting the best outcome is the first time you operate, always.
got it. Yeah. Well, we talked about my father. Let's talk about your father. He was a Freudian analyst.
Yeah.
We're about the same age. I think I'm a little bit older. During our lifetime, probably no thinker has suffered quite as severe a fall in reputation as Freud. What do you find useful in his work? Or if
Well,
there
again,
is anything?
I'm going to take issue with that comment.
Okay.
I don't think that it depends on your lens and it depends what you're looking at. So if you look at Freud from a feminist lens, let's say, and you feel that he didn't treat women fairly, that's a totally valid complaint. And I would not argue against that. However, if you take Freud as a brilliant man living at a certain moment in time, I think you have to evaluate historical figures within the context of their history. We can't move ourselves out of history. You can't view Freud from a modern lens. But um, what I value immensely in Freud's work and I think he was 100% correct, although I disagree with the way he framed it, but he did it, in a Victorian way, is that we like to think that we are in control of our decisions, of our behaviors, that there's a self, an identity, an ego, that we have agency, and that our ability to make decisions is sort of very rational and thoughtful. And what he did, just as Darwin and Copernicus did, was sort of upend that and say, no, the ego is only one part of the psyche. There's this superego and there's an id and this unconscious that is making an enormous amount of decisions for you and compelling your behavior and influencing what you do and how you decide what to do. I think he didn't go far enough, is my opinion, because I don't believe there is a self or an identity or free will in the way that most people do, sort of the common sense notion of it. And I think that the unconscious or the id or the superego, whatever you want to call it, um, and in my mind, what I call it are just modules in your brain that are processing information below the level of your awareness, are essentially making decisions for you. They're assessing the world around you. They're predicting possible futures based on different behaviors, and they're telling you, well, you should probably behave this way because we want this outcome. And they're compelling you and making that decision as to what to do, what decision to make, how to behave, constantly. And so I think Freud, brilliantly saw that, with no equipment and, using what tools he had. But unfortunately, there was a lot of baggage that came along with his brilliant insight based on being, a psychiatrist at the turn of the century. And I don't think we should judge that so harshly.
Yeah, I'm impressed by the impact he had on the creative community. I mean, for much of the middle 20th century, it seemed all these different artists were just fascinated by Freud. So I wonder, if we shouldn't just also consider him a poet, in the sense of that the influence he had there.
Yeah, he was a wonderful writer, a wonderful writer. And that was a lot of what was compelling about him, was his rhetoric. He was so convincing because he wrote so well. But
Mhm.
those were the tools that were available to him. He couldn't do experiments in a laboratory. We didn't have the ability to measure any of the things that he was trying to measure. So all he could do was talk to people and write compellingly about his ideas through his rhetoric. And much of it was wrong, but the basic core of it was brilliantly insightful, is what I would say.
Mm. Yes, and I think that perhaps we can uh, reinterpret his insights a little bit when you talk about the Oedipal complex. Maybe an evolutionary scientist might think, well, we have some sort of module that wants to challenge for power, and some sort of module that is frightened about what might happen if you challenge for power. And it might not be that we're projecting uh, our experience of our parents onto the world, but that we're projecting our genetic wiring onto our parents.
Yeah.
Uh, yeah.
The way I look at it is, evolutionarily and biologically, uh, we are born into this world of two parents, you know, and if you look at the way, I'm just watching a documentary with Jane Goodall about, the way chimpanzees, live in the forest. There's an alpha male that controls the group and makes certain decisions for the group, and that's our DNA. We were born that way, because of strength and the importance of physical strength in surviving on this planet, if you will, hunting, gathering, whatever it takes to survive and keep a community intact in the face of so much adversity. And so there's constantly a friction evolutionarily between young males and older males. It's a fight for power, if you will. That is
Mhm.
built into our DNA.
Mhm.
And you can look at any major corporation in the United States. There's a power structure and there's a fight between the junior partners and the senior partners. And it doesn't matter now if they're men or women anymore, because we're we're somewhat past that to some extent, although it still exists, of course.
Mhm.
And so I think Freud was just getting at the fact that because we evolved the way we did on this planet with a history, um, a lot of those conflicts and mechanisms and stories pervade the way we think and impact the decisions that we make, and the conflicts that we have that lead, and those conflicts can lead to psychopathology and anxiety
Mhm.
and depression and fear and anger and all those things that weigh on us every day. And if you can try to understand where they come from, you know, which was
Yeah.
really the goal of Freudian analysis, you can try to move beyond them and then lead a more healthy life.
In your book and also just in our conversation so far, you've talked a little bit about free will, and I will note you were a philosophy major in undergraduate school. Um, I agree with you. I don't think there's free will. I think if you commit to a physicalist view of the mind, it's hard to think, well, what is it that would be free willing? You know, it's neurons working under biological and physical forces. But I guess my question for you is, what is the best way to live with that? What does it look like to say, try to be the best neurosurgeon you can be if you don't have a free will?
Um, the key is to um, put yourself in positions. And even the problem is the language, our free will and agency in the self is built into our language, right? So anytime I use English or language to describe my thoughts, I'm describing them inaccurately because you're talking about put yourself, like, well, who's the self? You can't use the word self. So take that with a grain of salt when because it's the only tool I have to describe these things, and so that you'll understand them or anyone will
Mhm.
understand them. So that said, um, what we can do is to put ourselves in situations to help ourselves make the best decisions that are advantageous to whatever it is that we're trying to accomplish with our lives. Um, and uh, I think that the mechanism of the brain, the algorithms running in our brains are different for each one of us, and they're based on our unique DNA and the unique interactions that we've had with the outside world throughout our entire lifetime, interactions with our parents, with our teachers, with our children, with our spouses, and at work. Um, and if you want to be the best uh, football player you can be or soccer player you can be, you need to put yourself in a situation where you're going to be practicing every day, hours a day, with a coach telling you what to do to get better and better and better. And you need to set your alarm. Your alarm has to go off every morning, and you have to eat well and get out of bed. And you could say what I'm the saying that there's no free will to it is that you just have to be the kind of person that allows yourself so that the external forces acting on you will help you achieve whatever your goal is. I guess is how I would put it. So if I want to
Yeah.
be a great neurosurgeon, um, you know, by going to a lab and practicing my skills, or by going to bed early and exercising every day and putting myself in a situation where I can get as many reps as I possibly can to get better at what I do, forcing myself to write papers, lecture, um, all of those things will make me a better neurosurgeon, as opposed to me just saying I want to be a better neurosurgeon. I have to allow the world around me to program my brain in such a way that I become a better neurosurgeon, I guess is
Does
how I
it
would.
does it seem to you that maybe, okay, we don't have free will, but it's a good illusion to have? Because you're speaking in the terms of willing yourself to be a better neurosurgeon, to put yourself in that situation.
Yeah, I
Is it
think
a good illusion?
we live, it is an illusion, but we live our lives as if we have it. Um, I'm a big as if person. You know, you have to live your life as if, and free will is part of that. So you have to imagine that you can will yourself to become what you want to become, and that will help it happen, but it won't happen in the way you think it's happening. It'll happen because you put yourself in situations that allow it to happen, is how I would describe it, as opposed
Mhm.
to you making it happen um, on your own through your own
Okay.
agents.
Well, we're coming into a new age of deep brain stimulation and brain computer interfaces. What advances in neuroscience and neurosurgery would you expect over the next decade? And what do you see as your involvement in them?
Well, I'm very excited about brain-computer interfaces, which is a technique a lot of people now, technology a lot of people are aware of because of Elon Musk's Neuralink. But it's a technology that's been developed since the 1960s. It has a long history. Neuroscientists and neurosurgeons have been working on brain-computer interfaces for decades, and they're very sophisticated, and there are multiple groups all around the world who have functional brain-computer interfaces that essentially allow us to put electrodes in the brain, record the signals in the brain when a human being is moving their arm, moving their lips. A lot of it is about taking movement out of the brain as opposed to raw thought, and putting that into a computer so that the computer understands what the pattern of firing of those neurons is and what it's coding for, so that just by thinking about moving your arm, you could move a robotic arm, or just by thinking about moving a cursor on a computer screen, the cursor will move, because every time you are thinking about moving that cursor up, there's a similar pattern of firing of neurons in the brain, and an electrode can record that pattern, teach the computer what that pattern is coding for, and the cursor will move up until you can do it very quickly, and you can type on a keyboard, and you could, in theory, drive a car, fly a plane, just by thinking about doing it. So that's a very exciting technology, because now an enormous amount of money is being put into developing the technology, and the computer programming now, the power of machine learning and what computers can now do with AI, and the combination of the two, smaller electrodes, better computer analysis, that coalescing of those two technologies is allowing us to develop very powerful brain computer interfaces that, in a couple of years, there'll be a few commercially available ones where if you're paralyzed in a wheelchair, they can implant one of these things in your brain. And even if you can't move your arms and legs, you could work on a computer, or more excitingly, I think, control either a robotic exoskeleton that moves you through the world,
Mhm.
or controls a robot, a virtual you that moves through the world doing what you're telling it to do. And you could be wearing goggles to see what it's seeing, and earphones to hear what it's hearing. And you can have a virtual double of you that's a robot that's just in the world doing things while you're sitting at home, in your wheelchair. So there's an enormous amount of potential. Getting information into the brain is much harder. Taking a blind person and letting them see by stimulating their visual cortex, we don't have the ability to do that yet, because at this moment, all we can do is create little flashes of light. We
Mm.
can't create real vision at the moment. Um, but it's, we don't have the technology to do that, but at some point we may get there. But there's so much we can do just by getting information out of the brain related to movement, that that's a very exciting area. And I think there'll be neurosurgeons implanting brain computer interfaces. Um, it'll become one of the more, popular things that neurosurgeons do going forward, in addition to all the other surgeries that we do. So I'm looking forward to getting more and more involved in that. My main focus is on brain tumors, and I love
Yeah.
doing brain tumor surgery, um, either, taking out tumors through the head, or doing what we call minimally invasive surgery, where you put a little scope up the nose, or you make a little incision in the eyelid and
Mhm.
try to get tumors out, leaving a very small footprint on the human skull and face.
Wonderful. One last question. Uh, I feel like humanity's sort of been pushed in by two sides here. On the one side, you neurosurgeons have been poking the brain with electrodes for at least 80 years, and and coming out with memories and movements and all these sorts of things that for me seem to prove that the mind is just physical matter. And then on the other side, you have the computer scientists have come up with large language models and generative AI that creates things that we would undoubtedly consider creative if they came from a human being, that has this relational ability so that sane people are saying that this is their best friend, their lover. I guess my question is, do you think seeing the brain as a machine, do you feel that that makes being human or less special? Or do you think that it makes life less sacred?
No, I think it makes it more sacred, because the way I look at it, if you are a physicalist, a determinist, and you believe that we evolved through random interactions of molecules, um, and the forces of evolution and adaptive survival of the fittest, it is a miracle that we evolved. The probability of ending up with the complexity that we have on this planet, um, is one in a, bazillion, trillion, numbers that I can't even comprehend. Um, and so that makes what we have so special and so unique. We are the product of the universe behaving in a very unusual way, in a very miraculous way, almost. Because and when I say miracle, I don't mean a religious miracle. I mean something that's hugely improbable. Um, and so we should be incredibly lucky. It's like, if you closed your eyes and took a basketball and threw it over your head 20 times full court and made every single basket, you should be like, woohoo, I made all those baskets. Well, that's basically every morning that you wake up, something like that miracle has occurred because of the improbability of doing that. We have won the lottery just by being here, sitting here, talking to each other. And so that's why you can have this materialistic view of the universe, but it's not a soulless, sad, cold, dark place. It's a beautiful, miraculous place with every sunset that you get to appreciate, every interaction with another miraculous human being next to you, is a beautiful moment.
Dr. Schwartz, thank you so much.
You're welcome.